Good evening, everybody, and welcome to Fertility Week. Tonight is the first of our webinar series. This year, Fertility Week is entitled Meet the Usual Suspects, and it's about the most common causes of infertility in New Zealand. Fertility New Zealand is a registered charity. We've existed for more than 20 years, and we provide support to New Zealanders with fertility issues. We do that through the provision of information, a lot of which is on our corporate website. We provide support that's predominantly through a network of volunteers that run support groups around the country, and advocacy. Tonight's webinar will be a presentation which will be followed by a Q&A session. During the presentation, if you have any questions, please just type them into the chat box and they'll be answered at the end. So I'm pleased to introduce Dr. Neil Johnson. He is Medical Director at Fertility Plus in Auckland and a renowned expert on endometriosis. Over to you, Dr. Johnson.
So thank you, Nicola, and good evening. Can you hear me? I hope everybody can hear me. And Nicola, please, if you, I have to say that I'm very, very inexperienced. This is the first webinar that I've attended, and I find myself speaking at it. So I'm very excited about it. And yeah, so just to actually, Nicola, if you're still with us, how do I get the presentation on full screen for myself? I'm sort of struggling with that a little bit. Just whilst that's happening, just a little bit of background about myself. So I am a fertility specialist, and I'm the medical director at Fertility Plus, and I'm also with Repromed Auckland as well, and in addition a gynaecologist at Auckland Gynecology Group, and both of those latter are at 105 Remuera Road. I'm fortunate to hold an honorary professor position with the University of Adelaide, which involves a research collaboration, and also a position with the University of Auckland too. I've been on the board of Endometriosis Zealand for, I think about a decade now, and also on the board of the World Endometriosis Society. And yes, and I'm now also the president-elect of the World Endometriosis Society. So I hope that I'm qualified to speak a little bit about endometriosis. And so what I'm going to do now is to click into the next slide, which I suppose gives a little bit of an essence of what is endometriosis. And Nicola, if you can sort of prompt me either by texting me if I'm going off track a little bit, or I'm hoping that your questions will appear on the screen at some point. So what is endometriosis? Well, I think most of us know that it's the presence of functioning endometrial type tissue, so inner uterine lining type tissue, outside of the uterine cavity. So on the ovaries, the fallopian tubes, the vagina, the cervix, the uterine or ovarian ligaments, in the little pouch behind the uterus, that's the pouch of Douglas, the bowel, the uterus, and the bladder. And as a consequence of that tissue being, it sounds a bit weird, tissue where it shouldn't be, but it is perfectly benign actually, endometriosis, and has really almost no implication for malignancy, but it does cause inflammation of these tissues as a result, and as a consequence of that causes both pain and fertility problems. So Just moving on to the next slide. And I must say I'm really grateful for Nicola putting these slides together. I really appreciate that. I did check and vet them, and I must say that you've done a fantastic job putting them together. So thank you. So what happens to the endometrium in normal circumstances? Well, estrogen is produced by the follicles in the ovary and promotes growth of the normal endometrium. It then the cells in the lining absorb the estrogen, and this promotes the growth of the endometrium, and then ultimately the endometrium is shed with a period. What happens to some of this endometrium is it goes backwards up the fallopian tubes. We sort of call it retrograde. Some people call it retrograde menstruation, and it comes out of the ends of the fallopian tubes and can spread throughout the pelvic cavity. And its peritoneum is the lining layer, and sometimes it can actually implant in there, as well as onto other structures like the bowels. And normally it just then gets reabsorbed, but there is some evidence that women with endometriosis have higher exposure to estrogen or estrogen receptor sensitivities. But I think probably the key thing is the immune response within the pelvic cavity, which doesn't really promote the reabsorption of these endometrial cells, so they implant and start to grow. There may be a bit of genetic pre-programming of that, and so I suppose that endometriosis in rare circumstances can occur very, very early in women, or in fact in girls' lifetimes, even before they've ever had a period. So there must be other mechanisms, I think, at play of the cells going down a sort of a pathway that they're not really supposed to go down. But the bottom line is that one ends up with growth of the endometrium outside of the uterus, and in addition, there is an abnormal inflammatory reaction to this tissue. So, I suppose this leads on to the question, well, that's all very well, but why is endometriosis associated with infertility? Well, and actually the next slide, I'm just going to click into the next slide, which is the same as that slide, but just has something slightly different with it. And I think the first thing is that the first point made there, I think, probably should go to the bottom, really. But I think the first thing is that if you have a lot of pain, then the keenness to engage in sex is much reduced. So couples where the woman has endometriosis are less sexually active, and in fact, it can, particularly around the time of ovulation, which can be quite a painful time for women with endometriosis, that can pose really big problems of actually gearing and timing sex to the right time of the cycle. Secondly, obviously there's scarring and damage. The fallopian tubes. Whoops, that's Ascot Hospital calling me. I'll call them back. Sorry about that. Didn't really expect that. So there can be quite a lot of scarring, and this can damage and block the fallopian tubes, or it can distort the relationship of the fallopian tubes to the ovaries. So I think you can see why, in some circumstances, the egg and the sperm can't then get together. There is some evidence that endometriosis damages ovarian reserve, so it can actually substantially reduce one's one's ovarian reserve, either because of endometriosis on the ovary or sometimes because of the need for surgery. So the condition itself within the ovary and the surgery for it can reduce ovarian reserve. And then finally, there can be more subtle impacts on fertility. So even though there may not be scarring or damage or reduction of ovarian reserve, and even though there may not necessarily be so much pain with sexual activity, the environment within the pelvic cavity can be quite different. So different cytokines are released there, and that of course is where the eggs are growing, the sperm and eggs are interacting. So it can impact on the quality of eggs, and it can impact on the sperm and egg interaction, and also impact on the transport along the fallopian tubes. And then the final thing is that even though the endometrium itself, the inner uterine lining where the embryos are trying to implant, appears normal, molecularly it can be different, and it behaves differently, and it's a wee bit less receptive to embryos that are trying to implant into it. For example, there are some molecules called osteopontin, and I don't know how much many of you know about the endometrium and its receptivity and the molecules that it's supposed to express, but it's supposed to express integrins at the time of the implantation window, and they're expressed only fleetingly, and they interact with another molecule called osteopontin. And conditions around that time for the embryo first to stick and then to implant are very exacting. So we know, for example, that women with endometriosis, in their endometrium, there's less osteopontin expressed. No, actually, sorry, that's I've got that wrong. There's actually more osteopontin expressed, and the conditions are quite exacting within the uterus at the time of implantation. So there's a lot of different mechanisms for reduction of fertility in women with endometriosis. Now, I think I'm getting a question. I don't really know if I should say the name of the people who've submitted the questions, but I had an operation to remove my endometrium about five years ago. Could it have now come back and now be causing infertility? Well, that's a good question, and unfortunately the bad news is that in a reasonable percentage of cases, probably up to half of all women, the endometriosis can come back and will come back even after good surgery. I suppose the good news is that means that half of all women only ever need surgery once. In fact, probably over half only ever need surgery once. But there is that tendency for it to come back, and certainly it can come back and can be responsible for causing infertility. Whether surgery is then the answer to it is a debatable question, because we know that the first surgery is the best surgery in terms of improving symptoms of pain, etc., and also in terms of improving fertility. And subsequent surgery is just never quite as good in terms of improving fertility. So I hope that answers your question. Please keep the questions coming if you'd like to. Now, so I'll just go back up to what the symptoms of endometriosis are, just to go over that. So typically it's pain, and that can be pain related to the period, pain at ovulation, or pain with during sex, and that tends to be a deep pain, felt deep within the in the abdomen, and that really is quite a telling sign of endometriosis. And if one has that symptom, it really isn't a normal thing to have deep pain during sex. So that really should be looked into, and endometriosis entertained as a possible cause of that. Now, it also affects the bowel, but of course over 90% of women with bowel symptoms related to endometriosis don't have primary bowel endometriosis that's actually affecting the bowel wall. It just happens to be there, and these interleukins within the pelvic cavity create an environment that can cause bowel-related pain. So irritable bowel type, well, firstly, one can have bowel pain, and that of itself is quite a telling sign of endometriosis also. But even just more subtle irritable bowel type symptoms, so diarrhea, constipation, combinations of the two, bloating of the tummy. And also, let's not forget that endometriosis can sometimes be without any symptoms at all, or relatively minor symptoms, and so it can remain undiagnosed. And really, unfortunately, the only way of accurately diagnosing it is with a laparoscopy. Yeah, so if you go to the doctor, it can be suspected because the doctor examines you and there's tenderness in certain areas. There may be some nodules for the doctor to feel, or there could be a clear cyst on the ovary. Yeah, but really it can only be diagnosed by the presence of characteristic lesions that we see at the time of a laparoscopic procedure, and of course that's something that has to be done under general anaesthetic. It's keyhole surgery, but it is an operation, so clearly it's invasive. We're working at the moment, and there's a big sort of thrust of research going on to try to identify less invasive methods of diagnosing endometriosis accurately. You're not really there at the moment, and the one that we've used over the years, the blood test, which is the CA125 level, unfortunately isn't very accurate because many women with endometriosis don't have an elevated CA125 level, and many women without endometriosis do have an elevated CA125 level. So there's other reasons for that. Actually, coincidentally, it's also the ovarian cancer marker, believe it or not, CA125. So I always warn my patients not to go off Googling and thinking that I think that they've got ovarian cancer if I'm sending them off for a CA125 blood test, which I sometimes do. Certainly if it's elevated, that would give one a very strong suspicion that there might be endometriosis and might encourage the doctor, the specialist, to recommend a laparoscopy where they otherwise might not. So in terms of the medical treatments for endometriosis, the sort of, I guess, conventional medicine, I think we're going to come on to some kind of alternative or complementary therapies a bit later. So really the good thing about a laparoscopy and diagnosing it is that you can then go on at the same time to have the endometriosis removed laparoscopically. And the way that we like to do that is, if it's not in a sort of a key area, is to excise it or to actually cut it out, especially if it's a bit deeper, because sometimes the lesions may look superficial, but they can be a bit deeper. So that's a bit of a trap for the unwary gynecologist, and that can lead to the need for further surgery if it's not all removed properly. So we do endeavour to remove all of it as much as we can. If it's, for example, on the surface of the ovary, we tend to use what we call ablation, which is usually these days it's a kind of it's an electrosurgical thing called diathermy, but it's effectively heat treatment. It sort of melts it away, and then the healthy tissue grows back in its place. There are medical treatments, so that's surgical treatment really. There are medicines for endometriosis, and probably the big group would be the progestin hormones, and they come in various different forms. The problem with them, they can be taken in tablet form. You can have an intrauterine device called the Mirena, and that can be quite effective for women with pain with endometriosis. But the problem with progestins is that they're quite good, well, they're very good contraceptives as well. So that's not really a great thing for women who are trying to conceive. There is another category of medications that isn't on here that's actually also important in infertility and in relation to IVF. And that's called GnRH analog treatment. And you may have heard of Zoladex. I don't know if anyone's interested in it, but or if anybody's interested has actually had that treatment. But traditionally it's come in the form of a monthly injection. It's a bit heavy duty though, and it's often associated with side effects. And this really is a big problem with some of the medical treatments of endometriosis. Now I'm just getting a couple of questions through, so I might just pause, and I'll just read it. I don't think that you can actually see these questions, but I've got a question from a 25-year-old who has endometriosis and PCOS and has had 3 operations in the past. In the past 2 years from 2 different surgeons. And I'm wondering what your thoughts are on freezing eggs. Well, that's a very good question. And what your thoughts are on PCOS and my chance of carrying, of actually getting pregnant and of carrying a pregnancy. So there's a few questions there. I mean, that's a bit tricky. I really do try to avoid too many operations, but sometimes even my patients find themselves in the situation of needing different types of surgery to really enhance fertility, in terms of egg freezing, that's actually something that's really been a question that a lot of people are raising now in relation to endometriosis, because not only can sometimes endometriosis affect the ovaries and damage the ovaries, but of course, as I mentioned already, the surgery itself can have a damaging effect on the ovaries, especially if it has to be extensive or if it's not carried out expertly. One would hope that it would be carried out expertly. Egg freezing has now become an option, and I think if you've got a situation where there is a real threat to ovarian reserve from the disease itself, a big endometriotic cyst on the ovary, a big endometrioma, and also needing significant surgery to remove that, because sometimes it has to be removed both for pain and for fertility improvement. Egg freezing certainly becomes an option. Now, what about egg freezing? Well, a lot of, we do egg freezing in New Zealand, as you probably realise, but and it's not like we're really behind the rest of the world, but really internationally, although there've been an awful lot of eggs frozen, there haven't been that many thawed. So we're still just making assumptions that the thawing of eggs will go as smoothly as we hope it will. For example, at Fertility Plus, we haven't really done any thawing of eggs to any great extent thus far. But we are freezing eggs, and there is a defined method and way of doing that, and we have got now good technology of snap freezing eggs. It used to be a real problem before we had the vitrification methods of quickly freezing eggs, because the eggs were quite unstable to the freezing processes and often got damaged by it, whereas freezing embryos and freezing sperm has been done for many years, for decades, and that's well worked out. But it's really only in the last decade that egg freezing has come to the fore. As a 25-year-old, and particularly if one's needing a lot of surgery, then it is something that probably you do need to have a chat with your specialist about. It's always handy if your surgeon happens to be a fertility specialist, and then they can they can discuss that with you. But you can come along to clinics like Repromed and to Fertility Plus, the clinics that I work at, and discuss freezing eggs. The ideal candidate would be under 35, which you are, yeah, so I think it's certainly worthy of discussion, especially if one's looking at a need for yet further surgery. One of the good things about polycystic ovary syndrome is that women with PCOS tend to have, to some extent, a better ovarian reserve than women who don't. So that's actually one of the quite good things about PCOS. But the problem with it from the fertility perspective is that sometimes those eggs aren't easily released at ovulation. If you've got endometriosis and PCOS, that can be challenging because you may need treatment for both of those things at the same time. But in terms of egg freezing, whilst I suppose there's a risk of over-response and the condition that we call ovarian hyperstimulation syndrome, if one's freezing eggs and going through I suppose the IVF stimulation type of process in order to freeze eggs. But I would say that it is something that is worthy of discussion with your specialists. I've got another question coming through. Saying, why is it best to try and conceive within the 6-month period after laparoscopic surgery from removing cysts, but there is such a big waiting list for government funding for IVF? I'm on a waiting list of 12 months from my first doctor's appointment. From trying to find out why I haven't conceived till now, has been over 2.5 years. Yeah, no, I mean that really is a big frustration, and the problem, I suppose, is the eligibility for publicly funded treatment, which many couples don't become eligible for until 5 years after they've started trying. So that would be the situation in unexplained infertility. I guess one good thing is that endometriosis, especially if it's more significant, can generate a few extra points for getting access to publicly funded treatment. But yes, there is a big frustration about the public waiting lists, both for surgery as well as for fertility treatment, including IVF. One strategy is that you can get, if you're covered by medical insurance, you can sort of jump that waiting list and get surgery undertaken privately. But of course, there has to be another reason other than fertility for most insurance companies to fund that. And so just that concept of conceiving within the 6 months following laparoscopic surgery, there does appear to be a fertile window. I'd probably say it's more like 12 months, in fact. But we'll come to talk about Lopidol in a moment as well, and that's a fertility treatment technique that I've done quite a lot of research on, and I wrote my MD thesis on it. And again, Lopidol is something that generates a fertility window of just 6 months. So the thinking is really that, and I suppose in simple terms, that the clear out that you get from surgery, it remains clear for a defined period of time. And as I was starting to say a little while back, there is that potential for endometriosis to recur and for the sort of the conditions to regenerate again. So women do find that there is this fertile window of maybe 6 to 12 months following surgery, and that is also true of Lopidol as well. So yeah, I might just move on to the next slide, and I will come back to some of the excellent questions that you're asking, because actually, in fact, I'll carry on with the questions while they keep flowing. So somebody else saying, I was diagnosed with endometriosis 7 years ago and had it removed by a laparoscopy. I then had my son, and we've been trying for a second baby for 3 years now. I had another laparoscopy and no endometriosis was found this time, and subsequently been diagnosed with secondary infertility. What treatment would you recommend? Oh, well. Yeah, that's yes, it's not an uncommon story, that, although it does seem rather strange that that you've had the endometriosis removed, and then of course pregnancy itself can have a healing effect on endometriosis. It does say on this slide that we've got up in front of us that some women's bodies heal themselves, and the progesterone hormone, which is a predominant hormone in pregnancy, can sort of hold the endometriosis and allow the body just to heal it. So I mean, it's really good that you've had the surgery, and there is now no evidence of endometriosis. Yeah, it puts you into an interesting category, a sort of a funny category in a way, and a frustrating category, because there doesn't appear to be, I suppose, a clear-cut cause for fertility now. What I would say is that once you've had endometriosis, that's sort of a diagnosis that really stays with you. And, you know, I think you've done the right thing in pursuing surgery and seeing if it had come back, because, you know, the first time around, the surgery seemed to do the trick, and it would have been nice if there'd been a little bit of endometriosis that could have been removed second time around, and it could have done the trick again. I would have thought Lopiodol would be a suitable next step, and it's a much lower invasive option than other options. I might just click down my slides into what treatments, because I think your question has led very nicely into what fertility treatments can assist women who have endometriosis, or women who have ever had endometriosis. Because I think certainly when we did our first trial looking at Lopiodol, that really started in the year 2000. So we did a trial for about 3 years, and to our surprise, what we found was that it was effective as we'd expected in couples with pure unexplained infertility without any history of endometriosis. But where the woman had a history of endometriosis, whilst in the non-endometriosis group there was a doubling of the chance of getting pregnant over the next 6 months, in the endometriosis group it increased it probably 4 or 5-fold. And we were a bit amazed by that, but actually we've looked again and again and again, and published quite a lot on this, and we found that it continues to prove to be a very effective treatment for women with endometriosis. Now everyone's saying, well, what is it? So it's actually a hysterosalpingogram technique, or an HSG. And so that's the old style X-ray dye technique that used to be used to diagnose problems with the fallopian tubes. And in fact, Lopiodol about 40 years ago used to be used as the standard contrast medium in hysterosalpingograms. It's actually, as the slide says, it's an iodized poppy seed oil. And it probably is an effective flusher of debris from fallopian tubes that doesn't actually block them, but that somehow hinders fertility. So it is important to have normal fallopian tubes, or at least one normal fallopian tube, when you have a Lopiodol procedure. But probably more importantly than that, it's the immunobiological response to Lopiodol. Firstly, once it's gone through the fallopian tubes in the pelvic cavity, but perhaps more important than that is an immunobiological response that we're seeing within women's endometriums. And we've got unfortunately it was a small study, because it is a big ask to ask women to give us some endometrium at the time of the implantation window when they've just had a Lopiodol procedure. So we're very grateful for those who did participate in this study. But we have seen these changes, and I mentioned the molecule osteopontin earlier on, and in fact Lopiodol downregulates that. So we know that women with endometriosis overexpress that in their endometriums, and that it is quite an exacting thing in terms of the implantation mechanism. So it's quite a useful treatment. And I think it may be a sensible next step. I do. A lot of women come to see me in my fertility clinic because they know that I've got a strong special interest in this, and I've sort of developed this from research level. So if you're struggling to find someone to offer it to you, then I'll be more than happy to oblige, because I am still very strongly interested in it, and it's just been an amazing journey actually with this research, and we've seen some wonderful outcomes. So I expect that to continue. So there's Lepardol. What are the other treatment options? Well, stimulated IUI. It's sort of, people have questioned whether it's actually really that great for women who are ovulating, and where there isn't actually so much of a fertility problem, and particularly in the context of endometriosis, people have said, well, is it really going to get round the issues with endometriosis? Because all you're really doing is getting washed, higher quality sperm closer to maybe a couple of eggs, having taken something like clomiphene tablets to stimulate the ovaries. So that's IUI, or stimulated IUI. And then, of course, there's IVF. And of course, we've talked about surgical removal. Now, okay. So there's a question: do we recommend Lepardol treatment for endometriosis? Yes. And what are the success rates? So, about there's about a 50-50 chance of conceiving naturally in the 6 months following this Lepardol, when it's done as a one-off procedure, and that's couples who are endeavouring to conceive naturally, as long as the fallopian tubes are fine, etc. So it really does work very well. It's it's not too expensive. It's in the region of $1,100 when it's undertaken through private. So compared to the cost of an IVF cycle, it's considerably less expensive. I'll just go back now to a couple of the questions. So now there's another question here. What effect does an endometrioma on the ovary have on ovulation? That's an interesting question. I had one removed during surgery, but it had grown back within 6 months post-op. Yeah, that's that can be a big problem, the one of recurrent endometrioma formation. It shouldn't really impact too negatively on ovulation, although it can make ovulation painful, unfortunately. But it shouldn't mean that you don't ovulate. So it's not classically a cause of not ovulating. So really, ovulation should really carry on in spite of having an endometrioma on the ovary. But we know that having endometriomas on the ovary, especially if they're of a decent size, up to 4 or 5 centimeters or more, does have quite a negative impact on fertility. And it's probably this thing that I was talking about the creation of a less optimal environment for the eggs to be growing within. So I think I've answered all the questions at the moment, so I might just go back to the presentation as it is. And then we've got alternative treatments, and it's, such as herbs has been raised here. So there's just excuse me a tick. Yeah, so one of the things at the outset of the webinar was one of the themes, I think, was how to protect your fertility for the future. So I suppose that this self-help really relates to that a little bit, and if possible, start trying for a family by the age of 30 was put down here. I mean, sounds easy, doesn't it? And yet there are many factors that come into play. But I think there is no doubt that for women with a history of endometriosis, it's a good idea not to delay pursuing a pregnancy unduly. I think with that kind of history, when fertility is an important life goal, it is important to get on with it if possible. Yeah, there are some alternative therapies that have been highlighted here: naturopathy, nutrition, and acupuncture, and they're interesting ones in relation to fertility. Probably most of the evidence that we have in the IVF arena is around acupuncture. That does seem to help a bit, particularly where there have been repeated IVF failures, I suppose, with acupuncture, particularly on the day of embryo transfer. It does also say that some women find that some foods, dairy, coffee, and high-fat diets can aggravate the symptoms. And I think I would add to that gluten, because that does seem to be a big aggravating factor for the symptoms for a lot of women. It's really hard to find the hard evidence that shows that these sort of complementary approaches have an improving effect on fertility. But look, you know, I would not claim to know everything about this condition. I suppose our problem from the medical perspective is that we do have fairly stringent requirements on how we judge whether something is an effective treatment or not, and we usually base it on clinical trials, on randomized controlled trial evidence, and it's really that just those trials haven't been done for a lot of the complementary treatments. But I think Lula George, a very dear naturopath colleague of mine, provided some of the information on this slide. So she's promoting a high-fiber diet, which helps remove excess estrogen through excretion from the bowel, and that may well be true. And is also very keen not to overload the liver, saying that going into some theories about liver detoxification of the body, and is also talking about limiting the exposure to environmental estrogens or estrogens that are found in all of these things, pesticides and phthalates and insecticides, and that seems reasonable. Although once again, the environmental causation of endometriosis and also the infertility related to endometriosis is not brilliantly well worked out. Lula said optimize weight, and that's always a good idea in relation to fertility. I don't think it applies any more to women with endometriosis than to other women with fertility, and to men with fertility issues as well. And exercise is always a good thing. I think in terms of exercise, if the problem for some women with endometriosis is that they can't do high-level exercise, but there's certainly quite a positive impact from the endorphin release that one gets from doing exercise, and that can help to have a controlling impact on pain symptoms. So yeah, now I think there's another question coming through or come through here from saying, I'm 31 and have had endo for over 10 years with 2 laparoscopies to remove it. I've been trying for about 6 months now, and my doctor won't refer me to a fertility doctor until I've been trying for up to 12 months. Why is this? Over the past 5 years, I've been trying on and off, ending up in hospital with headaches, etc. but no one will refer me. Yeah, so I think the thinking there from the doctor may well be that that one doesn't become eligible for publicly funded fertility treatment until there's been cumulatively 12 months of unprotected sex. So it may be that, given what you've described here, that if you've been trying on and off for 5 years, it may be that the number of months in total is a lot more than 6 months. So perhaps the doctor doesn't have a clear idea of that. So it may be worth just re-explaining that and saying, look, that you've taken some advice and that the actually the cumulative number of months over time, going back over 5 years, is X number of months. So so that is something that that you could do. Yeah. Now, I'm just getting another question here. Sorry, there's a bit of a delay from me, but I'm just actually reading the questions as they're coming through. Someone's saying, can you point us in the direction of any research published on Lopardol? And the short answer is yes. It may even be worth just Googling Lopardol. A good way of searching medically that I quite like is using PubMed. And if you just Google entrée PubMed, the French word entrée, and put that with PubMed, and then if you the key one that it pulls up, and then you can just do a keyword search on anything, and that's really an effective published medical literature way of searching the published medical literature. And if you just put in the keyword Lopardol and fertility, that's or Lopardol and infertility, or Lopardol and endometriosis, and that will bring you up the research. I think, Nicola, what I should perhaps do is to send you a couple of, well, perhaps I'll send you my most recent paper on Lopardol, which really just summarizes the whole story. And it was published in Anne's Job, the Australian New Zealand Journal of Obstetrics and Gynecology last year. But it's, dare I say, it's quite a good summary of where we are with Lopardol at the moment, and our current understanding of it and all the evidence on it. So we've had quite a few publications over the years. We published our original trial, which is called the FLUSH trial, standing for Flushing with Lopardol for Unexplained Subfertility by Hysterosalpingography. That was a bit of a mouthful. And then we've done another trial called, or a sequence of trials called the LUBE studies, which stands for, now that we understand a bit more about it, Lopardol Uterine Bathing Effect, so LUBE, the LUBE study, recognizing that it probably is more of an endometrial bathing than a tubal flushing, which is what we used to think it was. So I think we're getting towards the end of the webinar now. So if you have more burning questions, please do fire them in. I must say that healthy hormone foods isn't really my area of expertise, although I will flash up this slide for you because Lula's very kindly provided it. I'm not sure whether the so-called healthy hormone foods are specific for endometriosis or for improving fertility in general, but it seems to me that most of the superfoods have found their way into this list. So it seems to me like a very good list of fantastically healthy foods, and I think Lula's right. Many of them do provide low levels of natural hormones as well. So yeah, I think now that we're into the last 5 to 10 minutes of the webinar, I thought I'd perhaps just draw things to a conclusion. And I suppose one of the key themes was at the outset was protecting fertility in the future, and that is quite a difficult thing to really address. I think we've touched on it a little bit tonight with the very good question about egg freezing, and I think now that technology has improved, that becomes a very real option for women, particularly in their 20s, as you are 25, considering the option of egg freezing. I think it is a conversation that young women, especially those in their 20s who are needing to have repeated operations for endometriosis, particularly if it involves surgery actually on the ovaries or for ovarian endometriomas, it is a conversation that you should be having with your specialists now as to whether it might be a good idea to be freezing eggs, because there is no doubt that some women end up, even in their early 30s, with really profoundly reduced ovarian reserve. Sometimes it's obviously more the exception than the rule, this, but there are some women, even late 20s, early 30s, with profoundly reduced ovarian reserve because of the damage that endometriosis has caused to the ovaries, and particularly endometriomas. So I think in terms of that overall protection of fertility for the future in relation to endometriosis, I suppose my themes are be aware of endometriosis as a possible diagnosis, and that's as much a note to self and to colleagues as it is to my patients. But it doesn't always necessarily mean that you have to dive in with surgery if one suspects endometriosis, but and I think suspected endometriosis or suspected recurrent endometriosis can be a very reasonable diagnosis to have, and it doesn't necessarily, as I say, mean that surgery has to be undertaken, because there are other relevant treatments like Lepidol, like stimulated IUI, like IVF, like even the more natural approaches to improving fertility. And I think on that note, I think it's to some extent, I wish that all my patients that I see in the fertility clinic went to see a naturopath, because I think there's really a lot of value in getting the lifestyle right, and getting diet right, with the goal of fertility in mind. Yeah, I think it is right that one should, if there is a background of endometriosis, be aiming to have children perhaps sooner rather than later, is a better way of saying that. You know, maybe before 30 is a good aim. And if there is infertility with endometriosis, you know, I think it's good to consider the various fertility treatments specifically toward endometriosis, as we've said. Laparoscopically removing it, you know, that's best at the first surgery, but there is still a beneficial impact from subsequent surgeries. Lepidol, as we've said. One thing that I should just mention is that if one's struggled with repeated failure of IVF, there is actually a bit of evidence that suppression with what we call GnRH analogues, or Zoladex was the one that I mentioned. That's unfortunately the one that can cause menopause type of side effects. But treating with that for 3 months in the lead into IVF has been shown to really quite dramatically improve the chance of success, of successful outcome of IVF for women with a history of endometriosis. So I think that I suppose that what I've learned over the years is not to give up with this, and ultimately there will be a way of treating both the symptoms that can really lead on to quite a lot of misery, unfortunately, for women with endometriosis. But there is a way of dealing with the symptoms, and there is almost always a way of getting a positive and a successful fertility outcome. The problem is that, you know, sometimes one has to be quite resilient in terms of putting up with a lot of treatments, and we're mindful of that. Not to mention quite rich when it comes to having to undergo perhaps repeated privately funded IVF. Now, I think before I close, I think time's almost up, but I just have had another question or two. Okay, well, I'll quickly try. So, are other immune problems related to endometriosis? Since I was a baby, I've had asthma and eczema. Then when I was in early teens, I developed anaphylaxis to shellfish and tree nuts, but only found out that I have endometriosis since trying to conceive 3 years ago. Absolutely, there is a recognition of the autoimmune aspect of endometriosis, and there is a bit of overlap between endometriosis and other autoimmune conditions. So it's not a huge overlap, but it's not uncommon to find other autoimmunities amongst women with endometriosis. You seem to have been a bit unfortunate to have had quite a few, but that is a recognised phenomenon. And now there's another question: is there any benefit in having the Lepardol treatment prior to or in conjunction with IVF? That's an interesting question, and we have got a pilot randomised trial on that, and we're a bit disappointed with the outcome of that, because in relation to improving the chance of success from IVF stimulation and fresh embryo transfer, we did not find a benefit, which was a great pity, really, because we sort of expected to. That ultimately seems to have been explained by the fact that the endometrium, the inner uterine lining, becomes quite different in an IVF stimulation cycle. It gets swamped by a lot of estrogen, and therefore it's quite a different endometrium to what it is when one is trying to conceive naturally. So I still recommend it for embryo thaw cycles. So when you have your frozen embryos warmed or thawed and then replaced, we don't know for sure that Lepardol is helping in that situation, but sort of extrapolating from the beneficial effect in the natural fertility situation, it seems to me that particularly embryo thaw cycles are much more akin to natural cycle attempts to conceive naturally than the IVF stimulation cycle and fresh embryo transfer. So I hope that answers that question. It's perhaps not a brilliant note to end on, but I think now time is up. So I don't know if you want to jump back in at this point, Nicola. Unless there are any other questions, I'll be delighted to take them. But I think I've pretty much said all that I wanted to say tonight. Have I covered everything, Nicola?
Yes, I think you have. There are 3 more questions that I can see, but we are sort of running out of time.
Okay. Do you want to fire them at me quickly? I don't think I've got those. I think I've answered all the questions that I can see. Do you want to give them to me quickly, or it's up to you?
Okay, so the next one is, if you have PCOS and endometriosis, what are the chances of carrying / birthing a full-term healthy baby? Are there risks to the baby?
So, short answer, pretty good of carrying a full-term healthy baby. I mean, there are subtle risks to pregnancy from endometriosis, and but it isn't there isn't a strong thread of problems in pregnancy. So the chance of carrying to term are good. If you've got polycystic ovaries as well, then that increases the chance of gestational diabetes. But certainly those conditions do not pose any risks to the health of a baby, and are not associated with congenital abnormalities or anything like that. So that's reassuring.
Right. The next one is, I understand that endometriosis is genetic. Is there any way of reducing the chances of this for our children?
Oh, yeah, that's an interesting question, and the genetics is still being worked out. The problem with endometriosis is that it's not just one gene. It's many genes and probably many environmental factors. So I think reducing the chances in terms of passing it on to to our children when there's a history of endometriosis in the family, I don't know that there's a great lot that we can do about that, other than an awareness of the symptoms that it can cause, and an encouragement to seek appropriate care, appropriate medical care, and appropriate care from those who know what they're doing with this at an earliest stage as possible.
Great. The last question is, I had an HSG 18 months ago and tubes were clear. Would I have to have another before doing the lipidal treatment?
No. It rarely ever changes unless there's been something really significant happening between, like a pelvic inflammatory episode or pelvic infection. So I usually take tubal patency testing from 5, even 10 years ago, unless there's been some history in between that suggests that it's changed.